Welcome, everyone, to our citywide psychiatry grand rounds. This is a co-venture for the University of Toronto and Sunnybrook Health Sciences, and it's a pleasure to have them co-host this wonderful event. And I know we got people from University of Toronto as well as across the country and across the globe, so welcome. We have a very tight presentation, so I'm going to begin right away. So I'm Raj Singh, the CPD Director. I'm going to read our online land acknowledgement. We would like to recognize many Indigenous nations that have long-standing relationships with the territories upon which the sites of the Department of Psychiatry is located that precede the establishment of the University of Toronto. We acknowledge our presence in the traditional treaty of many Indigenous nations, including the Mississaugas of the Credit, the Anishinaabe, the Chippewa, and the Haudenosaunee and Wendat people. Today is the land to home to many diverse First Nations, Inuit, and Métis people. We're grateful to have the opportunity to live, work, and gather on these territories. We acknowledge that Toronto is covered by Treaty 13, signed with the Mississaugas of the Credit, and Williams Treaty, signed with the multiple Mississauga and Chippewa bands. Since this is a event that's a virtual gathering, a singular land acknowledgement does not capture the richness of our distribution across many locations. There are few places on earth that someone before us has not called home. So thank you for that. I'll quickly go over the agenda for today. Great pleasure to have Dr. Mark Sinyor present today on a wonderful topic. So thank you all for joining. Evaluation link will be sent at the end, and please, we appreciate your feedback as always. The next citywide psychiatric grand rounds is the Paul Garfunkel lecture, which will be on November 29th. We hope to see you there as well. I'm going to stop sharing my screen, and I'm going to introduce Dr. Sona Gain, who's the chair, Department of Psychiatry at Sunnybrook Health Sciences, to introduce our speaker. And welcome. Go ahead, Dr. Gain.
Well, thank you, Dr. Rasasingham, and very appreciative to have this opportunity to introduce our speaker for today, Dr. Mark Sinyor. Dr. Sinyor is a staff psychiatrist here at Sunnybrook and an associate professor at the University of Toronto. His research focuses on population-level strategies for suicide prevention with an emphasis on how media messaging impacts suicide. He's published more than 100 peer-reviewed articles on the topic of suicide, and he is the International Association for Suicide Prevention's Partnerships for Life lead for the Americas, and lead author of the Canadian Psychiatric Association Guidelines on Responsible Media Reporting about Suicide. He's also created a free mental health literacy curriculum that teaches middle schoolers coping skills and distress management while reading Harry Potter and the Prisoner of Azkaban in English language class. And here at Sunnybrook, Mark is instrumental in our suicide prevention work, which is a priority focus of our department. And we are also appreciative that Dr. Sinyor has agreed to present these rounds. I must not tell lies, what Mozart, hip hop, and Harry Potter can teach us about changing the narrative to prevent suicide. So with that, Mark, look forward to your talk.
Thank you so much, Dr. Gann, for that exceedingly kind introduction. And my hope is that between Mozart and hip hop and Harry Potter and suicide prevention, there'll be something of interest to everybody here. See if I can advance my slides. The only disclosure relevant to the talk today is the one that Sona just mentioned, which is that I have a Harry Potter-based intervention, which I've been working on for the past decade, well before all the controversies about Harry Potter. And my bias is that I still think it's of value, but I guess you'll maybe weigh in later and see if you agree with me. My hope in this rounds is to tell a story. And the story starts with a series of emails which I received about 5 years ago from a group of colleagues in the UK and Australia who said that they were organizing a Lancet commission on suicide, which, as you can see from the title of this slide, later got broadened to the more general idea of self-harm. And they asked whether I would be willing to lead the pillar focused on society-wide efforts to address self-harm. And I had two reactions to this question. The first reaction was to think that this is a deeply meaningful thing that if I can contribute to, I have an obligation to do it. And the second one was to think, how on earth am I going to figure this out? Essentially colleagues saying, can you work out how the world should address self-harm at a societal level? And so I'll tell you where that went in a few minutes, but I want you, as you hear the presentation, to think to yourself, if someone asked you that question, what would your answer to that be? And my answer is going to be something to do with culture and to do with environment. But before we talk about that, I want to show you the chapters in my story, which you see here. And the first chapter is the problem. And here I'm going to start with a meta-analysis, which was led by Fiona Maloney and with lead author Rachel Mitchell. And thank you to Fiona and Rachel for allowing me to show your amazing work. And this was a meta-analysis looking at non-suicidal self-injury in adolescents. And here you see the results. And I think there are two key takeaways to pull from this figure. The first one is that rates of self-injury around the world in adolescents are very high. And the second one is that if we drill down into North America, which you see here in the middle, we have the greatest sex difference in self-harm. So 1 out of every 12 or so young men self-injure, and that's quite a lot, but not compared to young women who self-injure at about a rate of 1 in 5. So it's a really big number. And now to turn to suicide data, Rachel and I have been collaborating with a colleague at the University of Melbourne, Matt Spittle, on a series of what are called age, period, and cohort effects. And here I'm showing you data on birth cohorts in Australia and their suicide rates. And if you look on the left, this is males. What you see here is that those who were born around World War II had the lowest risk of suicide, and then the risk climbed for birth cohorts that went up to about the mid-80s, and then it started to decline. But if you look at females, you see something different. Again, lowest risk in the sort of baby boom generation. But as you move to successive generations, risk increases quite dramatically, up until you get nearly threefold rate ratio, which is an extraordinary number in the most recent birth cohorts that were born in 2000 and just beyond. And now if we pull back to Canadian suicide data, and here we're looking at Canadian youth aged 10 to 14, people in the audience are probably familiar with the gender paradox of suicide. So the gender paradox says that females attempt suicide more frequently than males, but males die by suicide more frequently than females. And that's usually mainly because of more lethal methods that are used by males. And you see in the first decade of this century that we saw a bit of that gender paradox. So young males had a slightly higher rate than females. But look at what happens here. So this is another of, as I said, Rachel's studies, and Rachel calls this the double, or the hockey stick, I should say. And so what's the hockey stick is that you can see that male rates are declining here a little bit, which is great, but the rates in females have, again, like in the last slide, have skyrocketed, and such that by a few years ago, there was no longer a gender paradox in suicide, that females both attempted and died by suicide more frequently. And that's a very unusual and important finding. So what's going on here with our youth, and in particular with our female youth? I think one way to think about that is to look at Thomas Joiner's interpersonal theory of suicide. And what Joiner posits is that there's a whole group of people who have a desire to die by suicide, but most of them will never even attempt, or certainly not die by suicide, because you need this other ingredient. And the other ingredient is capability for suicide, which you see here kind of in the middle. And if you have that and you have the desire, you might die. So the issue is that self-harm is a kind of enabler of suicide, because once you start self-harming, you probably have a decreased pain threshold, and you've demonstrated that you're capable of harming or injuring the self in response to an emotional problem. And so even if in the moment it's quote unquote non-suicidal, that becomes one of the biggest possible risk factors for suicide down the road. And so probably something about the proliferation of self-harm has increased the capability for suicide amongst our youth, particularly young women. And so as I said, in a few minutes, I'm going to argue to you that one of the key factors that we haven't spent enough time considering is the issue of culture. But I was never initially interested, or just wasn't researching culture. And so there's sort of a bridge in the story between the problem that I just told you about and the cultural solution, which I'm going to share. And the bridge is actually an actual bridge. This one, the Bloor Street Viaduct, which I'm sure people are familiar with on Bloor Street at Bayview and the DVP. And this is a photo of it being constructed more than 100 years ago in 1917. And very quickly after it was constructed, it became a suicide magnet, a place that people went to die by suicide, such that by the end of the 1900s, there were about 10 people every year who were dying by suicide at this location, tragically. And so in response to this, the city of Toronto installed a barrier at the Bloor Street Viaduct in 2003. And in 2010, Anthony Levitt and I published this paper, which had an unusual finding about the barrier. So all the suicides at the Bloor Viaduct were prevented. However, we found almost at the exact same number, an increase in suicides at other locations, other analogous locations, such that suicide by this method didn't change. And this was a very peculiar finding. I got pushback on this finding and originally thought that maybe I didn't know why that was happening, but then really realized that this really should have worked and there was something wrong with the finding. And we went back and we looked at what else was going on. And one of the major things that was occurring around the construction of the viaduct was some really problematic media reporting. So you see here an article that came out 2 months later after it was created or finished being installed in the Globe and Mail. And the article is entitled, "The New Suicide Bridge. An expensive barrier was built to stop people jumping off Bloor Street's infamous Bridge of Death. So now they leap from the," I won't say which bridge instead, but the Globe and Mail did say which bridge. And what we found when we looked back was that there were dozens of articles every single year for a few years around the construction of the barrier, which said things like, this is a big waste of money. People who are suicidal will find a way. And even here's another bridge, which is just a horrific, horrific thing to have put out. But probably what that resulted in was a transient media phenomenon that balanced the effect of the barrier for a few years. But what happens when you look out much further? So let's finish with the story of the barrier before we get to the culture. A big thank you to my recent former postdoc, Vera Men, for running these analyses. Here we were looking at much longer term data than that first study that we had published, almost 20 years of data since the barrier. And before the barrier, the Bloor Viaduct, those 10 suicides or so, accounted for about half of all the suicides by that method in Toronto. And when we look at 2 decades of data, we find that suicides by this method have been cut by exactly half. And in this long term, there's no evidence of a substitution effect. So means restriction works. It's one of the most evidence-based strategies for suicide prevention. Please don't let anyone ever tell you otherwise. But the problem is we also have to think about our cultural narratives, because for a few years, that seemed to muck up the intervention. Let me give you one more example. For those, I'm sure most people here have ridden on the TTC, or if there's anyone outside of Toronto, it's our transit system. And in 2011, the TTC created, in partnership with Bell Canada and the Toronto Distress Centres, a crisis link intervention, where people on the platform could call a hotline, speak to a crisis responder, and if there was an emergency, they could even get into transit control, the distress centres, and stop the trains. And you see here some of the advertisement for that intervention. So this is a study that was conducted by Selena Chow, my summer student, medical student. Amazing for Selena to have done a summer student project and gotten a Lancet series publication out of it. But it's really great work and interesting, I think. Tell me what you think. What happened is that after the crisis link intervention was installed, which you see here right in the middle of the figure, there was an almost 50% reduction in suicides on the TTC, which is amazing. But then look what happens. It kind of creeps back up to pre-intervention levels over the next decade. And one of the contributors to that is the media. We looked at media articles and found that for each additional media article that talked about suicide on the transit system, we saw a 2% increase in suicides in the following quarter. So we have to think about our messaging. We have to think about how we talk about these issues. And this brings us to Werther, young Werther. So here I'm showing you some covers of Goethe, the very famous German novelist, his novella, which is called in German Die Leiden des jungen Werthers, but in English, The Sorrows of Young Werther. This novella was published in 1774, okay, so it's a long time ago. And in the novella, this main character, Werther, is deeply and desperately in love with a woman. And ultimately, she rejects him for someone else. And in despair, at the end of the book, he sits at his writing desk and he dies by suicide. And after the book was published, there were a series, like a spate across Europe of young men who had had unrequited love. They were romantically rejected, dressing in the stereotyped clothing of Werther, which was a blue jacket, a yellow waistcoat, and high boots, sitting at their writing desk and ending their lives using the same method that Werther did. And as a result of this, the book was banned in a number of countries, Denmark, Italy. Goethe himself sort of spoke out against it. He tried to suggest to people that was not he didn't want anyone to copy the behavior of the character. But as a result of this instance, there was a term coined called the Werther effect. And the Werther effect is the effect of suicide contagion. And here I'll show you a prominent example of that. So here you see US suicide rates tracking about the same every single year over the course of the first few years of the last decade. But then something happened in August of 2014. What happened in August of 2014 is that Robin Williams died by suicide. And what you see here is that after Robin Williams' suicide, there was a skyrocketing of suicide in the US, such that there were almost 2,000 more deaths than expected. That was a 10% risk increase. And you can see even the year after, which is that dark black line at the top, it looks like it's even higher. Maybe even that doesn't even capture the whole effect. But they found a 10% increase in deaths after his suicide. And just for a point of comparison, the global financial crisis caused probably a 3%, maybe in some places up to a 6% increase in suicide. So this is a huge, huge effect. It wasn't confined to the US. So Rob Whitley, one of our colleagues at McGill, replicated this increased finding in Canada, and I was part of a team that replicated it in Australia. So this is a very serious problem. And if you want the entire literature on it, you can look at a meta-analysis. This was a meta-analysis that was conducted by Thomas Niederkrotenthaler, my colleague and mentor from the Medical University of Vienna. And Thomas included those 3 studies that you see at the bottom, and then a whole bunch of other studies that looked at suicide following the death of a celebrity. And what we found is that there was a 13% increase in suicides after media reports about a celebrity that has died by suicide. And it's a true increase. So you don't see a compensatory decrease in suicides afterwards. These really look like deaths that would not have happened but for the media event. Now, the slide that I just showed you shows a true story of suicide. Robin Williams was a real person. But of course, the Werther effect is named after a fictional depiction. And the most famous fictional depiction of suicide that resulted in a Werther effect in the past decade is 13 Reasons Why. And for those people who don't know, 13 Reasons Why was a Netflix series depicting the suicide of this character who you see here, Hannah Baker, who has a number of trials and tribulations, and she ultimately ends her life and sends tapes to people to explain to them why they did something wrong that caused her suicide. And the show violated most, if not all, of the recommendations for responsible reporting on suicide. It showed her suicide is essentially inevitable, and that help seeking was ineffective or in fact counterproductive. It sort of discouraged help seeking. And so this was another study that was led by Thomas. And in the study, we found that there was a 15% increase in suicides in young people in the US in the 3 months after the show, and that the increase was particularly notable in young women, the target audience of the show. And I just want to pause here for a second, because in the lecture, I'm going to show you a number of epidemiological slides. But one of the things is that humans aren't built to emote to epidemiology. But think about this. These are all people. The increase in the 3 months was about 100 teenagers. And so if I hope you haven't, but I know this is a group that, many probably have had a situation where you've been aware of or been involved in the suicide of a young person, or maybe, as I've done, counseled parents who have lost young people to suicide. To imagine that there are 100 more after a show comes out is, I think, kind of mind-boggling. And in fact, we replicated these results here in Ontario. This slide I'm showing you is not the mortality data that we replicated. I wanted to show you something else. And a big thank you on this slide to Emily Malia and Paul Kurdiak for making this study happen. But one of the things that the makers of 13 Reasons Why argued was that it was starting a helpful conversation, and that maybe some of the suicide mortality data I was just showing you is an outlier. maybe a lot of people benefited from the show and sought mental health help. And if that was the case, what we would have expected was more outpatient visits for mental health or pediatric visits, primary care visits. We didn't find any evidence of that. The only thing that we found evidence for was this quite startling increase that you can see after the red line in self-harm related emergency visits after the show came out. So one nuance I will share is that, so Thomas and I were working on the study I showed you a couple of slides ago, and it turned out that unbeknownst to us, two amazing colleagues from Ohio State University, Jeff Bridge and John Ackerman, were working on pretty much the same study with some nuanced differences, but very similar. And we ended up putting them out at the same time. And we were all, we're all friendly. And we said, you know what, we should say something about this beyond our studies. And so we got together and we wrote this article in USA Today saying, when it comes to suicide, not all conversations are equal. And the studies and the weight of the evidence and probably this article and many, many other articles written, including by some colleagues here at U of T and in various press, I think really influenced Netflix to drop the scene. So they made quite a startling choice. They cut out the scene where Hannah Baker dies by suicide. So if you now log on, you can't see that scene. It doesn't fix the show, but it just shows that advocacy and data can get you somewhere. Okay, so that's the doom and gloom portion of the talk. Let's talk about something happier. I want to talk to you about Mozart and logic. So we talked about the Virchow effect. In the Virchow effect, the way that the Virchow effect works is through social contagion. And social contagion occurs when someone identifiable does something that someone thinks is desirable, and then they do more of it. But that applies to anything. It doesn't have to be suicide. It could be survival. And so my colleague Thomas from Vienna coined the Papageno effect after imitative survival based on this character in Mozart's Magic Flute. Like Virchow, he has a romantic crisis and he's about to end his life. And then these three boys show up and they say, no, Papageno, don't do it. Use your magic bells. When Thomas presents about this, he says, I don't know what magic bells are, and I don't know either. But whatever it is, he uses them and he survives and sings a beautiful aria. And Thomas coined the Papageno effect on the basis of this study. And a huge thank you to Thomas for allowing me to show his slide as part of my presentations, because I think it helps you see what he did. So Thomas and his group looked at media reporting in Austria and found a lot of what everyone else finds, which is that stories of doom and gloom and hopelessness are associated with more suicides afterwards, like the Virchow effect. But he found that 9% of articles in the Austrian press had what he called the mastery of crisis class narrative. And you see an example of that here. It's obviously in German, but I'll take you through the title. Haarsbreit, a hair's breadth, am Selbstmord, from self-murder, which is one of the German words for suicide. Vorbe, a hair's breadth from past. A hair's breadth from suicide past. And it tells us the story of Martin. And Martin is a fellow who's in a suicidal crisis. Things are not going well for him. He's close to suicide. But then he does something interesting. He picks up the phone and he calls a crisis line. And he speaks to Claudia, who you see at the bottom here with her phone. Maybe it's a little bit hard to see, but she's depicted with her phone to her ear. And Claudia is a crisis line worker, and she walks him through it and talks him through the situation. And he starts a process of getting help and getting better. And by the end of the article, he's doing much better. And after stories with this narrative of mastery of a suicide crisis came out in Austria, there was a small but statistical decrease in suicide rates across the country. We ended up looking at that in a few different ways, but we replicated those results looking at Twitter data here in Canada. So the top line findings are exactly what I've just told you. When tweets from high influence people come out and they talk about death and doom and gloom and sensationalized news stories about suicide, you see more suicides. And when we had tweets that came out talking about suicide as undesirable, tragic, preventable, we saw fewer suicides. And I'll give you an example of that. This is my favorite of them. The tweet was, when police found Ingrid, she wanted to end her life. One day later, she wrote this. And this was a tweet that came out from CBC. And then you click on the link in the tweet, and it takes you to this article, which shows these two officers from the Toronto Police Service who had intervened for Ingrid when she was in her crisis. And then the following day, she wrote them a letter saying, thank you for saving my life. So after this kind of message came out in the Toronto media, there was a drop in suicides. There are a series of studies that show this kind of thing, and this is my favorite one. It's a sort of maybe a bit, a conflict saying that because I was an author on it, but really, the work in this study was done by my colleague Thomas Niederkrotenthaler, and the study was looking at a song by Logic, the hip hop artist, and the song is titled 1-800-273-8255, which is the pre-988 number, 1-800 number for the US National Lifeline. And the song tells the story of a young guy it's a hip hop song. This is our hip hop example. And in the song, there's a young guy who's in trouble. He's struggling. He gets suicidal. He starts to think, I don't want to live anymore. In the music video, he starts grabbing things to end his life with. But then he rethinks it, and he puts his the suicide methods down, and he picks up the phone and he calls a crisis line, this number. And he sings, I want to be alive, I want to be alive. And this song was performed all over the Grammy Awards, the MTV Music Awards, and so on. It was a very big thing. And in the month of maximum interest in the song, we found 10,000 fewer deaths, 10,000 more calls, forgive me. It's 10,000 more calls to the crisis line in the US and 245 fewer deaths. So what do we take away if we kind of pause and look at what I've just been telling you? If you show the wrong show with the wrong narrative, we see more suicides. But if you sing the right song, you sing a song of survival, we see young people doing things like picking up the phone and calling a crisis line and surviving, which I think is an extraordinary result. Okay, I promised you Harry Potter. So let's talk about the boy who lived. I was familiar with this phenomenon, the Papageno effect, for about the last decade. And I started to get really interested in this about 10 years ago. But my concern about it is, you have the article about Martin, you have the song from Logic, but these are kind of like natural experiments that are ad hoc. And what I thought is, well, isn't there some way to put this in the drinking water? Can't we take these ideas and deliver them in a systematized way? An obvious place to do that would be schools. And I was searching for something that would allow us to do that. And I ended up having a Jungian synchronicity experience. If you want that story, that's a whole other story, but I'll give you the condensed version. The condensed version is that in the morning, I was running a cognitive behavioral therapy group here at Sunnybrook, talking about CBT skills and how to overcome depression. And at night, I was reading to my then 7-year-old son, Harry Potter and the Prisoner of Azkaban. And I made this connection and realized that Harry was becoming depressed and learning some fairly straightforward manualized CBT skills to overcome his depression. Now, I then went and looked into it. J.K. Rowling has said that the Dementor character that attacks Harry in the 5th chapter of the book is patterned after her depression, and that she did CBT around that time, and that it saved her life. She credits it for that. But she never said that she embedded it in the book. But what happens after Harry gets attacked by the Dementor? In the 6th chapter, he meets a fortune-telling teacher who makes all kinds of catastrophic predictions about him, which then his friends and sort of more rational teachers do cognitive restructuring with him over the course of the next several chapters. The 7th book is a lesson where he and his friends have to do a gradual exposure to an anxiety-related stimulus with his de facto CBT therapist in the books, Professor Lupin. In the following chapter, we find out that Lupin's lessons are structured as a fear hierarchy. Anyway, it goes on and on and on. I don't have time to go through the whole story. I can give you a link that you can read about it. But the long and the short of it is Harry learns a series of very kind of clear CBT skills to manage his depression. And so I thought this was fascinating and spent the next 2 years of my free time working with the Catholic District School Board of Eastern Ontario to turn this into a curriculum that could be portable for young people. And the elevator pitch for the curriculum is, instead of spending 3 months reading Animal Farm and learning about the Russian Revolution, you spend 3 months with middle schoolers aged 11 to 13, 12 to 14, because that's the age that Harry is in the book. And they read it and they learn how someone gets depressed and how to overcome their depression. And so the curriculum, as I said, is 3 months long. There are 11 units. The first units focus on risk and protective factors and distress and resilience because they're kind of summarizing the previous 2 books. Then there's the chapter where Harry gets depressed and later gets anxious, and then we talk about how those things manifest. Then we teach the young people about thinking errors, and then we start working on some higher level strategies of how you can do activities that give a sense of pleasure and mastery, and even a bit on core beliefs. And the students graduate with as CBT wizards with a personalized list of stress busters that they can use to manage a crisis, as well as crisis lines and other things they can reach out to if their stress busters don't work. So a huge thank you to colleagues at Google Canada who I was interacting with for a different reason. And when they heard about this, said that they wanted to spend their spare time working to make it into a website. The website I would have made would not have looked like this, but we have this beautiful website that's at myowl.org, OWL for Optimizing Wellness Through Literature, and it's completely free. So I don't gain anything other than feeling very happy if you go and use the curriculum, but if you or your schools or things want to use it, please feel free to distribute it. And we've studied it. So for time reasons, I won't go one by one through all of these studies, but I'll summarize the data that we have so far on the intervention. And these were studies that were conducted by my former PhD student, Paula Conforti. And Paula did a bunch of really outstanding and fascinating studies where she showed that when you deliver this intervention, young people see reasonably sized reductions in depression and anxiety scores. They have improvements in coping, emotional regulation, and compared to controls, they seem to do a bit better in terms of suicidal thoughts and behaviors. And the improvements seem to be biggest in the young people who already are manifesting some kind of clinical level symptoms. They still have small impacts on quote unquote non-clinical youth, but that's a very good outcome if we can replicate it, which we're going to try to do and are in the process of doing for a universal intervention. So it turns out other people have been interested in this as well, and we're trying to take it around the world. So the curriculum has been translated into Chinese, and you can see here on the top a slide where you have a stress with a pin to bust the stress, one of the slides from the curriculum. And currently we have 1,200 youth in mainland China who are receiving the curriculum, and we're really curious to see what outcomes we find for them. And here you see a picture of my colleague Thomas from Vienna, and Thomas has a large grant in order to study this. He's been going all around the country of Austria, recruiting school boards to deliver the intervention in German, which it's also been translated. And that's going to start next year. So we'll see where that goes. Since we're talking about Harry Potter, and this is a sort of maybe a little bit of an offbeat, different pace rounds than some of the other ones, I thought you'd allow me a digression to share something about my observations about the book series. And that is that I actually think that the whole series is a hidden meditation on suicide. And the question of whether when you have a kind of an initial trauma, whether you can overcome it or whether it's going to envelop you. And suicide is sort of presented throughout Harry Potter. So, and specifically, it's attached to both Voldemort, the big bad guy of the series, and his ancestor, Slytherin. So the house elf for the house ghost for Slytherin is the Bloody Baron, who has died by suicide. Voldemort gives his henchman Wormtail a silver hand that later in the series he uses to kill himself. I should probably say that it's a spoiler alert, but it's been 20 years, so anyway, you could just ignore this part if anyone wants to read the series. Voldemort's mom, Merope, she has her own Werther-type romantic crisis, and in despair, she leaves Voldemort at an orphanage, and then she quote-unquote chooses death. The pub at the village where she comes from is called the Hanged Man. And there's a key story in the last book where Harry and Voldemort are seeking these hallows, and the most important hallow is something called the Resurrection Stone. And the Resurrection Stone is something that there's a fictional tale in Harry Potter about, and it talks about this brother. And the brother is seeking it, but he has his own romantic crisis. And it says, forgive me because I can't read it with this covering it, driven mad with hopeless longing, he killed himself so as truly to join her. And so to join the love that he's lost. And in fact, Harry himself becomes suicidal in the 5th book in the series, or at least it sounds like he does. He says, "I've had enough, I've seen enough, I want out, I want it to end, I don't care anymore." And this is in response to a bereavement. And in fact, the whole 7th book of the series is really focused on whether he'll use what happens in the Resurrection Stone to kind of exit, or if he'll find a way to leverage it to find survival. Anyway, there's a lot more to talk about that, but just to kind of bring it back to what we were talking about at the beginning and self-harm and its relationship to suicide, I thought it would be interesting to mention self-harm as it exists in Harry Potter, because there are a series of prominent examples of self-harm, but the two biggest ones, each attached to another villain, a lesser villain than Voldemort. So there's Lucius Malfoy, who forces his house elf to iron his hands, as you see on the left. And then there's Professor Umbridge, this evil teacher who is trying to get Harry to tell something that isn't true. And when he refuses, she forces him to write, "I must not tell lies," on his hand, which is the title of the lecture. And what's really interesting about these two characters is that neither Malfoy nor Umbridge is really a main villain in a way. They're much lesser, but they enable Voldemort. Their main sort of role in the series is to enable the big villain. And it's interesting that they're attached to self-harm and they enable the villain that's attached to suicide. In that way, on a symbolic level, Harry Potter really does a very, very good job of capturing the interrelationship between these two things. But okay, thank you for the digression. Let's move back to where we started. I told you about the Lancet Commission and the idea that they were asking about societal approaches to address self-harm, and I was a little out of my sorts. And what happens when you're out of sorts and you're not really sure what to do? I'll tell you what I would do: call your friends. So here is a photo of a bit of a grainy photo, but of many of the major folks who were involved in the Lancet Commission. And this was taken right after the pandemic restrictions were sort of lifted in a more substantial way at the end of 2022. We all flew to Australia to talk about how to manage this Lancet Commission. And this was taken right outside the Sydney Opera House. It's a selfie by Rory O'Connor, who you see here, who's the president of the International Association for Suicide Prevention. And right next to me is Jane Purkis, who has been my mentor in the area of suicide in the media for the past decade, and I feel incredibly lucky to have had Jane. So she is the director of the Centre for Mental Health at the University of Melbourne in Australia, and is just an incredible expert in the area. And when I didn't know what to do, I immediately emailed Jane and I said, "Help. I'm not sure if I am going to be able to come up with all of these solutions. Can you lead the pillar with me?" And she said, "Of course, don't worry, we'll figure it out. We'll find a great team." And that's what all mentors should do. It was a good thing to do. And in fact, she was right. We did. We found a great team. And our commission just came out 2 weeks ago on October the 9th. You see that here in the Lancet. And we identified 12 key recommendations. Again, because you see, I'm trying to get through a lot of material. I won't go through each of them individually, but many of them I think are common sense. We have to include the voices of people with lived experience. We need to make sure that services are available and that they're humane. We want to prioritize low and middle income countries where 75% of the world's suicides occur. We have to have a greater focus on Indigenous populations. It's obviously a very important issue here in Canada. And we need more research. So those are a bunch of the other recommendations, but I want to focus this portion of the talk on two. So the first one is we need Papageno stories. When we present self-harm and suicide in the public, we need to make sure that those stories have an incredible emphasis on survival, recovery, coping, and help seeking. And we can't do that alone in our community. We need the help of legislators, policymakers, but also the social media industry, because so much of the content now is distributed by them. And I hope at this stage in the talk that you'll agree that that's a really good thing. But that's culture. Remember at the beginning I said we were talking about culture and we need to change and think about how we shape our culture. And hopefully, again, you agree that that's true. But culture is not the only thing we need to change at a population level to address suicide. We also need to think of a whole of government approach. So how do we connect everybody? And why do we need a whole of government approach? Well, this is an editorial that was led by Jane, who I showed you a few slides ago. And in this commentary, she and we argue that it's really important that we think about the public health approach to suicide and self-harm prevention. All of us here, or I think many of us here anyway, are psychiatrists or psychiatric trainees. We work on indicated interventions. Someone comes to the emergency department and they're suicidal, and we have to help them. We have to admit them or give them an antidepressant or some therapy or neuromodulation. And that's very important. It's there. But that's not the whole solution. We also have to think about these upstream, selective, and universal interventions. If someone comes to the emerge and they're recently unemployed, maybe they do need an antidepressant, but that's probably not the most important treatment. We have to think about the antecedent factor that influenced this problem. And so if people are interested in the public health approaches that we can take to suicide prevention, the Lancet Public Health released a really nice series of articles just walking through how we would think holistically and globally about reducing suicide from a public health lens. And I won't go through all of them. I was involved in a few of them. Here's one that I just to give you an idea of why we need the whole of government approach. I thought I would focus on economics. And let me explain why. So inflation is a hot topic. Probably you're all reading things in the press right now about inflation. In red, you can see the inflation rate in Canada, which was quite low up until the first year past of the pandemic. And then in early 2021, you see this skyrocketing, right? Inflation went up to 8%. 8% is huge, huge inflation rate. And so what happens when inflation happens is that central banks like the Bank of Canada institute a contractionary monetary policy. And so what that means in practical terms is they want to slow down the economy. And the chief way that they do that is by increasing interest rates. And you see that here in blue. Right? So interest rates increase, and actually you see what the Bank of Canada wanted, which is that the inflation rate came down. And now they're lowering them because they're comfortable that it's come down enough. But there's a problem with that. Because when you increase interest rates, what you're doing is you're making the cost of borrowing higher. And what that does is it decreases aggregate demand. That's the purpose of the strategy. It's trying to decrease the total amount of goods and services that that the people in the country are trying to go after. But if people want fewer goods and services, then that means that there's less employment opportunity. So unemployment rates go up. And you see that very nicely here. Forget this preposterous kind of peak in unemployment that you see at the beginning of the pandemic, which is confounded by the income replacement that they had. But if you just follow the trend, if you look at before and after, by the time that subsided, unemployment in Canada was at about 5%. But as soon as these increases in interest rates occurred, you see the unemployment rate tick up by about 1.5%. Now, the problem with that is that for every 1% increase in unemployment, there's about a 2 to 3% increase in suicide rates in working age adults. And so what do you do about this? Well, that's why we need everybody at the government at the table. We need the Bank of Canada, so you tell them this, because maybe that would affect the way that they adjust interest rates. But maybe the Bank of Canada says, well, wait, but we have to. We're stuck. We can't allow inflation to go up, so we're going to do this anyway. Well, then we need the Ministry of Labor to start investing a bit more strategically in active labor market programs, or at least to provide some assistance and support for people who are recently unemployed as a result of this economic difference. So the best way to achieve what I just talked about, and because that's just one example, there's all sorts of different examples of ways that you might want to influence the risk across society. The most straightforward way is by creating a national suicide prevention strategy. And a huge thank you to Prudence, my lab manager, for helping me collate all of the evidence on national suicide prevention strategies for this policy insight. The short answer about the evidence is that it's mixed. But the longer answer is that when national strategies are really well designed and include the components, like what we just talked about, means restriction, attention to public messaging, some of the economic measures which I mentioned, when they do them in a really robust way, most of us are convinced that they're going to be very effective. And we're just waiting for that data to come in. Unfortunately, we don't have one in Canada. Canada is an outlier amongst G7 countries in not having a national suicide prevention strategy. And I want to thank the dozens and dozens of people who I think are in the audience here across the university who were among the 131 signatories on this letter that we sent to the Prime Minister in January, including, by the way, Alison Crawford, who is a key signatory. And so thank you to all of you, because we put this out there and said, look, Canada needs a national suicide prevention strategy. And it hasn't happened yet. Things are moving. We have a national action plan. That's good. It's not enough. But I think that through this kind of advocacy, we've started a conversation with our government, and I'm very, very hopeful that in the near future, we will be able to announce that there will be a national suicide prevention strategy. And I very much hope that U of T will be able to take a leadership position in terms of that work. Okay, last part of the rounds before we get to questions. I must not tell lies, which is the title of the rounds. And in fact, I'm just going to change it to we must not tell lies. See what you think. I'm curious your reaction, but my take here is that the evidence that I've shown you demonstrates that it's crucially important that we think about the messages that we send, the stories that we tell across our society. Because 20 years ago, around the Bloor Viaduct, we were telling really problematic stories. And those stories hurt people. I think they even resulted in deaths based on the data. We have to do better than that. We have to come up with better stories. And I'll give you just a vignette to help maybe hammer that idea home. This is a painting of Goethe. This is in 1808, so it was more than 3 decades after he had written Werther. And you see here seated that he is having an audience with Napoleon. Napoleon in 1808 was at the height of his powers. And you would think maybe that he would be, that Goethe would be starstruck by Napoleon, but in fact it was the reverse. This is the equivalent of a modern leader meeting Taylor Swift. Napoleon, sort of his eyes grew big and he said, I can't believe that I'm meeting you. Do you know that I've read Werther 7 times? And when I was on campaign, I was in Egypt, in my tent, in my trunk, I made sure everywhere that I went that I had a copy of Werther because I wanted to have it with me and to read it. And so why am I telling you this story? I'm telling it to you because, here's Napoleon, who at this moment in human history was the most powerful person in the world, one of the most powerful people ever in the world. And yet, what did he want to do with his time? He wanted to, in effect, binge watch that epoch's version of 13 Reasons Why. That may be a bit insulting to Goethe. The Werther is more sophisticated than 13 Reasons Why. But the point is that our narratives and our stories matter. The stories we tell matter. They affect people. It doesn't matter who you are. They make an impact. And so we have to make sure that we get them right. And in acknowledgement of this and the data that I showed you, the International Association for Suicide Prevention has made changing the narrative the theme of World Suicide Prevention Day going forward for the next 3 years. And so just a last few slides, summary acknowledgements, and then just a quick note. So in summary, and then we'll get to questions. I hope you see that suicide and self-harm are a serious issue and that we have an emerging issue of suicide increasing in young women. I hope you agree with me that public messages are crucially important in suicide deaths and that we need to think about Papageno narratives. We also need to think about those upstream determinants of health in a holistic way of preventing suicide, and Canada needs a national suicide prevention strategy. I just want to thank the whole team here at Sunnybrook and across Toronto and in fact around the world. I feel terrible that I can't squeeze every person that I work with into these slides, but it's just a pleasure to work with all of my colleagues. The data that I'm showing you today was generated by an army of people. And if anyone's interested, I'm always happy to talk to others. If you want to join the army, please give us a shout. Last 2 slides. For those people who are interested in becoming more involved in suicide internationally, this might be a little bit close, but if anyone doesn't have plans for the week of the 19th of November, please join us at the International Association for Suicide Prevention's first Pan-American conference. It's going to be an intimate discussion with some of the top people in the world and in the Americas on suicide prevention. And we have Patrick Kennedy, JFK's nephew, headlining it. And if for some reason it's too soon and you can't make it, I would understand. Please join us at the World Congress in Vienna next June. This is the largest conference in suicide prevention that exists worldwide. It happens once every 2 years. I'm co-chairing this conference. If you'd like any information about it, or if you're attending and you want to meet someone in your area, I would be so pleased to connect you with them and help with the collaboration and to enhance your work. I just want to make, in my last sentence, a pitch to say that we are a powerhouse in suicide prevention at U of T. Putting my hat on as a co-lead of Aspire with Juveria Zahir, I see all the incredible breadth and depth of suicide-related research and work that we do, and just interest in suicide. And I really hope that we have a large contingent of us there to really show ourselves at U of T at all of our work. And thank you again so much for coming and for your attention, and I'll stop there.
Thanks, Mark, for Dr. Sinyor for the wonderful presentation. As I said, every time I hear you speak, it's there's always more information and more data, and this is such an important topic. And thank you for presenting to our audience. As you can see, so many people are so thankful to this lecture and the content. So maybe we have some time. We'll go over some questions and maybe put others together. There was a question about a couple of people about how MAID is now forefront and center, and it's in the media, it's in the newspapers. And is there any, from your research or from your colleagues' work, is there any relationship between increased suicide rates and the media's portrayal or the increased media attention?
The short answer is that there's just not much literature on it. And in fact, it's a huge problem. We need literature on that. We did, I didn't show it to you, but we had a study looking at different kinds of content in the mainstream media in Canada and what happened after it came out. But it's a bit old. It was looking at the MAID debate before the Carter decision. And when articles came out about that, there was what looked like a little bit of a rise in suicides, but it just didn't rise to the level of statistical significance. Of course, the kind of debate now and thinking about the different people who are accessing MAID now compared to before is different. And so the main answer is it's a great question. We need more data. I don't know, but you have to worry about it.
Yeah, definitely. There's another interesting question here about universal income. What are your thoughts about that, social intervention or social determinants of health, and how that could impact suicide rates?
It's also it's a better question than I think the answer that I can give you. There have been a number of studies of a universal basic income. And to be honest, the results have been a bit mixed in terms of, just general health outcomes. I don't know that any of them have specifically looked at suicide, but it depends. Probably, one of the best studies that's come out in the last decade from low and middle income countries was by one of my colleagues at Harvard, Diane Machado. And she was studying something called the Bolsa Familia cash transfer program in Brazil. And what happened is they took certain people who had low income in Brazil and they gave them cash transfers with encouragement to do things like attend health appointments and go to school and things like that. And that intervention lowered suicide rates by about 50%. So I think there's something there, but we need more data to figure out exactly who and what and how to do that.
Thank you. There's a question here about schizophrenia and psychosis, schizophrenia spectrum disorders. What are your thoughts about the impact of media, for example, because those particularly experiencing delusions? Is there an increased risk of being affected by suicide or the contagion? Or what are your thoughts on that?
Yeah, so one of the interesting questions, which is a deficit of the methodology of some of the studies that I showed, is that they're population level studies. So we don't necessarily know when you see an increase, who are those people? Are those people with bipolar disorder or schizophrenia, or are those people with no mental illness who are just recently unemployed? It's tricky because on one hand, our data, not related to the media, show pretty clearly that people with these severe and persistent mental illnesses, that often the suicide is very illness driven. So someone, becomes psychotic, they believe the devil is after them, and they erroneously, think that they should die by suicide. And so I think a lot of that is really internal. That said, could it have some effect on some individuals? It's a great question, but it's hard to link, very difficult to link the epidemiology with that individual level knowledge.
Great. I know a lot of people are Harry Potter fans and just generally. There was a question here about, would you say that Harry was, quote, chronically suicidal? And would that be perhaps different in terms of interaction of external narratives in that circumstance versus someone who's acutely suicidal? What are your thoughts on
Yeah, I don't think that Harry. My sense of it is that Harry Potter was not intended to be a 13 Reasons Why type narrative. And it creates a problem, which is how do you tell a story about suicide and self-harm without 13 Reasons Why if the person is actually suicidal. And so there's an interesting technique that's used in the novel, which is Harry has this initial trauma of losing his parents. But the trauma and the suicide is presented as an external force, which is Voldemort. And the self-harm is also presented as an external force. But as the book kind of progresses, what happens is you find out more and more that Harry and Voldemort are alter egos, which often happens in like fantasy and superhero books, right? So it's like one can't live without the other. They're both internally, so one has to kind of go before the other one does. And I think in a metaphor, it's really asking like, so Voldemort, the word in French is Voldemort. It's the flight of death. And so the question of Voldemort is, does Harry fly towards death, or does he overcome his trauma and fly away from it? And I think that there is a metaphor there, which you can decide whether you think that attaches to suicide or not.
Yeah, great. Now, there's a question about, you mentioned about the national suicide strategy and your work and others on that. And I mean, there was a question generally about, is there a reason why it kind of took such a long time? Were there some barriers or challenges? Any thoughts on that?
Yeah, so you can find the answer to that question in a way embedded in the talk, which is that historically, and this is maybe largely our fault, we thought of suicide as simply a healthcare outcome, right? People have a mental health problem, they die by suicide, that's all that's going on. And if that's the case, it's a healthcare problem. Healthcare in Canada is provincial. So the federal government doesn't have to do anything about that. But the reality is that with our increased sophistication and knowledge in the area, we of course know that suicide is a healthcare problem. It's true, but it's yes and. It's also a cultural problem, an environmental problem, an economic problem, and so on. And so what we're kind of belatedly doing is going back to the government and saying, wait a second, that old paradigm isn't right. We need to move forward. And I think we've just been a bit late in getting with the program.
There's a question about, the 13 reasons why, obviously there's so much media coverage and talk about this. There's some questions about maybe an approach of kind of watching instead of sort of shunning away from, maybe watching it with your teenager and talking to them about it and explaining them or walking it. Do you feel that would be a good approach versus trying to, keep your teenager or your loved ones sort of separated from this type of content?
Yeah, I think it's never wrong to keep the conversation open. I guess the tricky part is the messaging in 13 Reasons Why is really, really problematic. And this is something that we're trying to ask is like, what happens if you have some problematic content, but then you have some useful content? So probably the useful content helps. If they have this whole series that basically says suicide is inevitable in young people, if you're suicidal, you should maybe go kill yourself. Having a parent there to say, no, that's not right. Like, let's think about this in a different way is probably useful. But we can come up with better narratives. I don't think that's a way to encourage more 13 Reasons Why narratives.
There's a question, and maybe a follow-up. It's a good follow-up to this, maybe. Can you comment on your thoughts about on implementation science, design, on narratives and strategies?
Yeah, so I'm not an implementation science expert, but I'm lucky to work with a number of them. And I think the way to think about that is just in this space. If you don't implement things well, you're lost. You can come up with the most ingenious strategy possible. We see that with school-based strategies. We see it with national suicide prevention strategies. There are some countries, they pass a strategy and then it's on the books and then they don't do anything. And then nothing happens. That's part of the mixed evidence. And so, that's probably its own lecture. But I think the first point is find something that's useful. And then from the very, very early on, think about how are you going to put that into practice, because the whole game is in the implementation.
Yeah, absolutely. You mentioned the Harry Potter program. I think some people are asking, is there a place they can access it and get this content?
So it's I think someone put it in the chat, I saw, but it's myowl.org. If you scroll through the chat, you'll be able to see it. It's designed for a school, so for a teacher to look at it. It's in the box or out of the box intervention where the teacher just kind of walks through their students with it. There are some videos on the website that you can look at to learn more about it. We're currently piloting a study here at Sunnybrook trying to reverse engineer it into an individual therapy to see whether kids or young people like to get CBT with Harry Potter rather than just run-of-the-mill CBT. So that might come at some point.
Wonderful. There's a comment about the decline in suicide rates overall, the data, the Canadian data. Could it be maybe some of this work or the work of your colleagues, has this had an impact on this? Or what are your thoughts on that?
Gosh, I'd love to take credit for that, but that's a for sure no. I mean, I don't think that necessarily the work that we've done here has yet had an impact on that. I think so. Rates around the world have gone down from 800 to 700,000 suicides, so that's a big drop. The outlier is actually in the Americas. We saw a bit of a drop during the pandemic, but things have actually creeped up a little bit back to pre-pandemic levels in Canada. So I think, look, it's sort of like the Bloor Viaduct story. I think the answer to the question is there are some good things that are happening, and then there are some countervailing forces. And so we need to sort of retain what we have, which is some of the positive messaging and some of the better access to healthcare, and then we need to kind of add all that other national suicide prevention strategy stuff, and then I think we will see the rates really come down.
One last question. Obviously, we're all compassionate about the Indigenous population and the suffering and challenges that they have. Any thoughts on contagion, suicide, within their community and how things could be tackled?
Yes, I mean, look, I'm not an Indigenous person, and I will say that I'm doing some work with Jeffrey Ansluis, who's at U of T, who is Indigenous himself and does fantastic work in this. And actually, I would suggest maybe having him as a future speaker. But if you take my take on it is, it's such an unfortunate thing because, in fact, from what I've heard from my Indigenous colleagues, suicide is not part of the Indigenous culture. It's quite the reverse. And now we've had a scenario where, for a variety of reasons that everybody knows, there is this situation where now Indigenous people are in a very difficult situation, and there is this probably a very serious contagion effect that has happened there. And I think we need to work to counteract it in the same way that we need to work everywhere. This is something that could be applied to any population.
Thank you, Mark. Thank you, Dr. Sinyor. So wonderful talk and amazing questions as well. I know we could keep going. We've come to the end of the hour. I don't know if Dr. Gain wants to say a couple of words. Thank you again for this wonderful presentation and all the time that you took to prepare this talk.
I'll just say thank you for all of your brilliant, compassionate, and scholarly work and advocacy, Mark, and excellent talk. Thank you.
Thank you. Thank you so much, everybody. Be well.
Yeah, take care. And if you have any further questions, you can always maybe reach out to Anne-Marie and we can, send it to Mark for feedback as appropriate. So thank you. And we'll see you all in a month's time in our next citywide psychiatric conference. Take care, everyone. Thanks you for joining.